Good afternoon, Dr. Clements. How are you?
I'm good. Good afternoon. How are you doing?
Doing great. And I'm so happy that you found time to stream with me live here on this beautiful April 28th. And I hear this is the first time you're doing this.
Yes, it is very much so. I am a newbie with live streaming and pretty much all social media. Still working on that front for sure.
Okay, well, you're just jumping into the cold water, and I think that's a great way to do it. And probably in many ways, it's an analogy to what you have chosen to do with medicine as well, jumping into cold water. But I'll let you tell the story yourself. I am always very interested in kind of the childhood, young adult phase of a person because I know it often shapes it sets those initial directions for people that they take in their lives. So if you want, tell us a little bit about that.
Yeah, so I'm actually from West Virginia. Um, that is West Virginia. Some people forget there's two states there. Huntington, West Virginia, which is a town, second biggest city in West Virginia, is probably about the size of Stone Oak, though, in San Antonio. So pretty small town. Um, and and got into medicine. I was introduced to it kind of through ski patrol. Is my first kind of dabbling in medicine in general, um, and that kind of got me hooked onto pursuing that as a career, I'd say. Went to medical school and residency in West Virginia, or sorry, went to undergrad and medical school in Huntington, West Virginia at Marshall University. And then did a residency at University of Virginia, so the other Virginia, UVA. And then when I graduated UVA, half my family moved to Texas, so we chased them all the way out here to San Antonio, Texas, is kind of where we set up shop here.
Yeah, and I know very often people who are involved in healthcare, they have very often their parents or close relatives who were physicians themselves. Was that the case with you as well?
Yeah, so my dad's a family practice doc,
Okay.
for
It's
sure.
just
Yeah, and
so
so
interesting.
mhm, he definitely started that in his. He doesn't have a family member or brother or parent who's in medicine, so he was a first generation, and then yeah, I'm a second generation
Mhm.
doc. Hmm.
And did you enjoy your time at med school? I hear it's very rigorous to get through all of that, both financially and also, of course, educationally. It's very,
Yeah,
very
yeah. Actually, I like to talk about the finances of medical training a lot because I think it's not talked about enough. I
yeah.
think people just say, "Oh, worry about it later," too much, and "Oh, you'll make enough money as a doc to take care of whatever debt you dig yourself into." And most of the time, that's probably the case, but the debt can get pretty extreme. So I think it's important for future medical students, future trainers in medicine, to consider the debt load when they take on. I love to talk to students about that, actually,
Mhm.
especially when they're undergrads and they haven't started medical school yet, because there's some moves they can make that probably help them out.
Mhm.
But yeah, that's a huge thing. I fortunately stayed. I made the decision to stay in state in West Virginia for my undergraduate degree, and so there were great scholarships available for people who are in state. So it didn't accumulate much debt at all in that phase of my training. And then yeah, medical school is expensive and
Mhm.
it's rigorous, and you definitely can't hold like a job while you're going to medical school. So it's you pretty much living off of a loan at
Mhm.
that point.
Mhm.
Um, but it was also in state. So there was an in state rate at Marshall University, which was, I believe, don't quote me on this, but I think it's less than half of the out of state rate. Maybe
Yeah.
that's different now. But so while I definitely accumulated some debt, it was slightly less than the national average um, because of those decisions of staying in state during my training and really considering the financial aspects. I mean, I think at the time that I graduated, it was like 187, $200,000 was the average medical student debt. I think it's way over that now, probably
Mhm.
$1,300,000. Many are $500,000 in debt by the time they finish.
Yeah.
Um,
Um, well, both you and I, we met here in San Antonio through an association called Free Market Medical Association that I'm kind of co-leading here with Dr. Roger Mochigemba. And the Free Market Medical Association is about alternative healthcare delivery. And I know you have such a model as well. So what is your approach? And also, do you start out like that, or were you kind of part of what we call a traditional model first?
Yeah, I'm gonna answer that second question
Okay.
first about what kind of led me into it a little bit, and kind of tie that in with the last question too about the debt. So I graduated like most students with a lot of debt, and so I was really drawn to the high salary, just work for insurance, work as an employed physician, get a big bonus. So I pretty much just chose kind of the highest paying position I could find in the private sector of medicine and traditional insurance-based practices. And definitely the debt's scary. So you don't really want to go and start a risky or what appears to be a risky venture and starting your own practice with that kind of debt already. So I went through the traditional route, and I did that for 2 years before I made a change over to direct primary care. We continued to live like residents mostly for those 2 years. So we were able to pay off that debt and create a little bit of a buffer to start a practice. And that's why I actually really like to, I'll get off that first question here in just a sec, I promise, but I keep
No,
swinging.
no, I love it actually. It's just
Okay.
something that a lot of people are not comfortable talking about, but I think we are all interested in it. Yeah.
Yeah, I'm really passionate about it because I think that the debt really affects doctors and clinicians' position on what they're going to do with their career, whether they realize it or not. And it was clear to me, I really wanted to do direct primary care. It wasn't in the cards for me because of the debt. And I think that if people get themselves in a better position financially and they don't let themselves get too far behind, then they have the freedom to do a model of care like direct primary care. Not that you get paid less in direct primary care in the long run. Actually, you usually get paid just as well, if not more, if you kind of optimize everything, just being a business owner. But definitely at the beginning, you're not going to get paid as much, and it's scary to go into that position. So yeah, I did private practice for a couple years with the financial aspects in mind. And then I opened my direct primary care practice January 1st, 2020. Yeah, so I think if I'm using this program right, I think I see maybe a question pop up there potentially, or somebody commented there. Okay,
Yeah,
absolutely.
it's a comment. Let's see what we have here from Andrea Ferguson. She says, absolutely true. From what I hear, physicians feel compelled to get the the debt off of their backs, right? Yeah, of course. And I will say also, I think it is normal that everyone is financially driven to some extent, and nobody should feel bad about that either. And as a matter of fact, I'm sure with your direct primary care practice, you eventually, as you mentioned, are looking forward to that being financially, rewarding, of course.
Mm-hmm. Yeah, I don't think we should expect anybody to take on a concept, a business model concept just out of the goodness of their heart. I think those are great things. Like there's sectors of the economy like that, but they usually, I think that for a real solution in healthcare, which I believe direct primary care and free market medicine to be, I think it has to be economically feasible and attractive to the people working in that system. And so you can't just ask people to do things just for the goodness of the heart, which, I mean, there's a lot of that in medicine. That's great. And that's how it should be. I mean, that's why we go above and beyond a lot of times the 9 to 5 kind of situation. But from a systemic standpoint, we need to make sure it's feasible and attractive. So yeah, and the debt for sure. I mean, what's crazy is if you calculate the interest on some of these student loans, I calculated, and I was below the national average. If I didn't pay off my loans quickly, the interest would have been $2,500 a month in interest. So not paying any of the loan.
Wow.
So it's
Wow.
insane. And that was less than the national average. So then you
Yeah.
take somebody who's like $500,000, their interest, I don't know, would be $8,000 a month or something.
Yeah.
It's insane.
Yeah. And the reason why I also like that you talk about this is because me, as someone, of course, who's not a medical professional, I know that before I was exposed to you all, there's this general feeling of, every doctor, every physician is just loaded. They just have money, and that's why we shouldn't feel compassion, shouldn't feel bad about them. They don't struggle, and that is not the case, because to get to where you are now, most of you invest 10 years of their time and money, and it takes quite some time to get out of that, to get to a point where you have time and financial freedom, which is something everyone deserves.
Right. And I'm definitely not saying physicians aren't, and I'm not trying to throw a pity party for physicians. Physicians are
Oh,
doing just fine, doing well.
yeah.
And I just think that that we need to make sure doctors are thinking about that so that they can do things that I believe are better for the patients and for the American economy and the population in general, for small businesses, and provide the model of care that doesn't require a ginormous extraction of financial pool from the insurance model. And from, this is leading us down a road here where I'm going here, but I think that if we don't accumulate all that debt as professionals, then we can do really more streamlined, cost-effective medicine, such as a direct care model or cash pay models. I can charge maybe, let's say, if I have, just as extreme examples, if I have $500,000 of debt, maybe if I'm providing a service, I need to charge $200 instead of $50 for that service if I don't have any debt. So it's just kind of simple business model, kind of I&O sheet here.
Right. Yeah. Yeah, as a DPC owner, you're definitely also a business owner, and that is a very important realization. And yeah, do you want to explain to us a little bit what your model is? Because I know not everybody is familiar with it. And I
Yeah,
believe you have like your own flavor to it.
I think our flavor is kind of the main flavor for what's called direct primary care.
Okay.
Direct primary care, DPC is what I'll call it going forward, is a primary care clinic. So we provide all the services. I know you know what this is, but for any viewers, is we provide primary care services like any other primary care clinic. But instead of billing insurance, we charge a simple monthly fee that covers everything in the walls of our clinic. So it's a membership-based model of care. That sounds simple enough, and a lot of people confuse it with concierge medicine because of the service we provide feels like concierge medicine. But the fact that we don't bill insurance and that we're an affordable monthly fee at $100 a month has a lot of implications on basically the population that we serve. And I think the feasibility as a replacement of the current healthcare system rather than just a niche sector. So let me clear this up a little bit. So we people confuse us with concierge because there is money out of pocket, and people pay for concierge. They pay insurance and they pay a fee on top of that, generally a retainer fee. And so it's always kind of more expensive. So it's often for affluent people who can afford, who just want better service. And people confuse us with them because we offer better service. We offer 30 to 60-minute appointments, same or next day availability. We offer when people walk in, I greet them at the door half the time. There's no wait time whatsoever. And you always have your clinician. You don't see just whoever's available. It's not assembly line medicine, is what I call it. And so it's that concierge level care. But because we don't bill insurance, what we found is, yes, we get people looking for concierge care. We get plenty of affluent people looking for great medical care, but we also get people who can't afford a traditional practice. We get lots of people who don't have insurance, or lots of people, like almost everybody nowadays, has high deductible health plans where if they went to another practice, they may pay several $100s, where if they pay us $100, they get an entire months of care, even if we see them 4 times that month. The $100 covers it. And then finally, one other service we add on that's great for people without insurance or high deductible care is we've created kind of a network of cash pay services in the San Antonio area, where if somebody needs something and they don't have insurance, we can get them a fraction of the cost for that service. So if somebody needs a simple blood test, it's 90% of blood tests we offer are $5 each. A thyroid check is $5. An A1C for your diabetics is $5. A testosterone check is $5. Your basic labs like a CBC, CMP, that if people don't know what those are the labs that we generally order once a year. Each of those are $5. Cholesterol, $5. And then we
And
can
what
get,
is that normally charged for?
most clinics will charge, well, it varies. So this is where I can tell you the price, but if you ask anybody else, they'll be like, I don't know, because it depends on your insurance situation. And so if you go through your insurance, well, once a year, it could be free as an annual. So sometimes for my insurance patients, I'll tell them, okay, here's your annual labs, bill it through your insurance. But then after that, you pay full price until you hit your deductible, generally speaking. And so a panel of labs that cost us an annual panel, let's say $25 with us, could cost $200 or $300 probably. Usually we're discounted by about 90% to 95%. Here's a story for you. In the hospital, with the delivery of our son, my wife had a CMP, complete metabolic panel. It's a really basic lab that we get all the time. They charged $1,800 for that blood test. $1,800 in the hospital. We charge $5 for that test.
I don't know of any other industry where such margins are possible. I mean, it's kind of, I don't know, it's crazy.
It is crazy, and you could go into the economics of it, and there's a clear explanation why the consumer and the seller they both want the price to go up. So it's just it's crazy out there. It's a fake economy where it's not true. There's no competition, and I mean the prices are just out. They're fake prices and they're outrageous.
Yeah. Our audience member here, Andrea, who is at the same time also working for Shanks, so that's why she's so knowledgeable about this.
Yeah.
She's sharing more data here with us. So according to
vitamin
her,
D.
a vitamin D lab, $232 at a traditional clinic versus 11 at a given DPC clinic. So that is another example of a huge discrepancy there.
Right. I had a patient and what's crazy is the prices are so low that often our people with insurance still do the cash price. So I had a patient who needed an abdominal MRI, and I said, okay, I can get it pretty cheap for you, cash. I know you have insurance, but just here's the cash price and consider that, because it was like November and she hadn't hit her deductible yet. She decided to go through her insurance anyways, which is fine. I mean, I don't know what her insurance situation was. And she ended up having to pay $2,000 for that abdominal MRI because that was her deductible. Well, we get the MRI for $350. So that would have paid for a year and a half of our membership of her entire primary care. If she went with us, we could have saved her that much. So yeah, even it's not just labs, it's imaging, it's other services too, ultrasounds. There's so many examples where we save money. And just to go down the rabbit hole a little further is high dollar medical care. So we think insurance is really for those hospitalizations or ER visits or things like that. And even in those scenarios, sometimes insurance isn't the way to go.
Hmm.
I'll give you two quick examples of how having insurance, we would have paid more if we used insurance for hospitalization, for two different hospitalizations. One, we've had two kids in the last 2 years. One kid was when we had traditional insurance through an employer, and the deductible was $7,500, and we paid the $7,500. That was the cost of having a kid, basically, with insurance.
Right.
The second child, we actually had dropped our insurance. My wife had left her employer, and we got something called medical cost sharing, which we can talk about another time. It's
Yeah.
non-insurance catastrophic care option. Um, and the deductible we got through them was $5,000. Our second child, we only paid $5,000 by not having insurance, and by having, for our entire family, we were covered for like $350 a month. Which, if we bought our own insurance for our family, for a $5,000 deductible, we'd be spending way over $1,000 a month for a family of four. So that's one example. And then the other example, I was hospitalized a year ago for a acute kidney injury, a little kidney thing. I'm fine now. And I went in the hospital for 30 hours, and I got the bill later. And I'm uninsured, but I had the cost sharing. So I was like, okay, I'm going to test this out. We'll see what happens. I have the cost sharing. We'll see if they cover it, and we'll see how it works, and see if I can recommend it to my patients as a good option. Well, I left the hospital. I told them I didn't have insurance because I did not. And I got home several weeks later. I got the bill, and as expected, it was $19,000, the bill. I was like, most people would be shocked by that. I'm not surprised. 30 hours in the hospital, $19,000. I knew it would be crazy. That sounds about right.
Right.
And so I was like, this is why I have medical cost sharing, because I have the $5,000 deductible through the medical cost sharing. It's not called a deductible with them, but it's the maximum you have to pay.
Right.
Well, it turns out I didn't even need that because the hospital gives a 90% discount to those who don't have insurance. So I only had to pay $1,900 for that 30 hours in the hospital. And that occurred a month after we dropped our insurance. If I had my insurance, if I got hospitalized a month before with insurance, I would have had to have paid $7,500. By not having insurance, I saved over $5,000.
Yeah. Well, I'm glad you shared that story, because I walk the talk myself. I have a DPC membership for myself and all of my employees, and then we have a cost sharing as well.
Yeah.
And it is really, the key here is really, you need to be curious, and you need to know what you can do. Like, for example, the fact that if you have a non-insured patient, you get a 90% discount, but there's so much to know that it's kind of impossible, especially for a layman. Like, you are a medical professional and you didn't know. So with cost shares, and also organizations like the FMMA, there is advocacy and education that really empowers people to just be more educated consumers in the healthcare space.
Yeah, totally. I think those programs are so important in terms of changing medicine for the better and making people aware of these things. And I think you're right. I think that I'm kind of lucky because I'm in the field, so I know where to find discounts and stuff. But people can hire that for them by having a direct primary care clinician for them at one of the 5 or 6 direct primary care clinic locations there are in San Antonio, and 1,500 throughout the U.S. So there's enough of us. Well, probably not enough. We need more direct primary care.
Well, I mean, it is a growing trend, luckily. So
it is. It's growing fast.
Yeah, and tell us a little bit about your practice. What does it look like? If you want to share, when someone signs up with you, what does their first month look like?
Yeah, so I do need to say we just brought on a new clinician, nurse practitioner Nicole Graber, and she's already filling up her panel of patients. And we cap at between 300 and 400 patients per clinician, which sounds like a lot, but I had over 2,000 in the traditional insurance model. So trust me, that's good care and not too many patients.
Mm-hmm.
So when somebody joins, they can register directly online through tailoredmd.com. Or if they have more questions, they can submit a message through the message system on the website, or by just calling the number. It goes directly to either myself or our office manager, Alejandra, there, who's also relatively new to our clinic. She's been with us just for a few months, Alejandra Zuniga. She's our office manager. But yeah, they register online, and then we always call them within 24 hours to schedule their first appointment once they register. And then we generally have, for new patients, even same or next day availability for even new patient appointments. When they walk in the door for their appointment, we greet them at the door by name because we don't have such heavy flow that we know who's coming in and when. So we greet them at the door by name, welcome them in, and we spend up to 2 hours with them for that first visit if necessary.
Wow.
Yeah.
You really go deep there.
We do.
Wow.
Sometimes it's just, sometimes people don't want to spend 2 hours with
Yeah.
their, and they got other things to do, and we respect that. So
Right.
I'd say we average about an hour. Sometimes people are in and out even quicker if they just want something taken care of. But we'll spend up to 2 hours with people to get to know their home life, their diet, their exercise habits, what they love to do, what their health goals are, if that's weight loss, or if it's getting better control of their diabetes, or if it's just preventing disease or cancer screenings. We do all that stuff, and we try to get it all taken care of effectively in the visit. And then going forward, we'll usually either schedule labs if they need that, or any screenings. And the cool thing is, because unlike a traditional practice, we're not paid to just have you come in the door as much as possible. We do things just whatever's efficient for you. So we'll say, okay, get labs, and we'll just give you a call when we get the results. So you don't have to necessarily come back in just to review some results. We can give you a call and discuss them then, or we can have a virtual visit where that's integrated in our electronic record system, where we can have a virtual visit with them, a video visit. So yeah, we do in-person, virtual, or phone call. And then also we text our patients. So if somebody's awesome. Like they need a refill, they'll just text us, hey doc, need a refill. And it doesn't have to be this whole debacle, taking half a day off work to get to our office in person, waiting 2 hours at the waiting room to see the clinician for 2 minutes just to get a refill. You don't have to do all that now. You can just text us.
Right. And this is available in San Antonio and the greater area, or what is your target region?
Our target, I mean, I have patients who travel up to an hour to get to us. I even have one or two people who just do virtual. I some college students who go out of state for college, and they still want to have access to the doc. So we'll do out of state as long as your primary residence is in Texas. Yeah, and then we're actually, I'll take this opportunity to talk about kind of an expansion project we have going on.
Yeah.
We're opening a program called SADPC, San Antonio Direct Primary Care. And I've been meaning to speak to Dr. Machi Gemba about this because I know he's a big figure in the direct care community. Yeah, so SADPC is it's a coalition of direct primary care clinicians to basically make ourselves more of a network and attractive to employers if possible. I think the biggest barrier to DPC in terms of expanding is consistency in the offering a lot of times. And that's a good thing and a bad thing. Like I think the DPC movement's about individuality and practicing medicine, and individuality in the business model that works for that clinician. And so it's kind of this pull on trying to kind of make some standardization, but not so much that the clinicians feel suffocated. Anyways, what we're trying to do is create some consistency. And so we have actually, there's 3 of us kind of combining under SADPC. And the website's, it's kind of a rough version right now, but it's pretty much ready. It's called sadpc.com, and that's live now. There's 3 clinics, myself, Tailored MD, with our 2 clinicians. There is Blue Bonnet, DPC, which is opening in King Williams in June, if everything goes well with them, towards the end of June. And then there's a pediatrician, Dr. Josephine, up actually near where I am, less than a mile away from my clinic in the medical center, that will take on pediatric care. If I could, maybe go to the About Us page, and that's where you'll see the clinicians listed there. Yeah, so there's the three docs. There's the three branches. Dr. Josephine's been practicing pediatrics for, I believe, 20 plus years. And she already has a lot of cash patients, and a lot of patients who are interested in kind of the concierge-ish level service of being able to call and text their doc and stuff. And so she's a good fit for adding on to what we're trying to do. And then scroll down. Oh, we don't have a picture yet for Nicole Graber with our clinic, but her picture will pop up there at some point.
Awesome. You know what I love is that, I mean, I'm pretty well connected in this community, and I still, like, I think I know everyone in San Antonio and the greater region, but I don't. Like, I haven't heard of these ladies, and it's amazing that it's just there's people coming together just trying to improve our healthcare delivery model here. That's awesome. I love that.
Yeah, I'm always surprised too. I think I know everybody too, and then I hear of one that opened up down wherever, and so for sure, I think it's like you said, it's growing very fast. It's kind of hitting that inflection point where it's becoming that kind of exponential growth
Yeah.
as we learn that it's a really viable model that's best for the two most important parties here, right? Like the patient and the person providing the care, like the clinician. Like these are the people that matter in terms of healthcare. And so this isn't worried about investors or like all these different private equity firms and stuff. This is true direct care. The patient's the customer, not the insurance company.
Right. Yeah, well, that's been very interesting getting to know you and getting to know what you're doing here in San Antonio. And so you do have, with your practice growing, you do have room for more patients. So that I definitely urge our viewers here to check out your website, tailoredmd.com. And if there are any final questions, because before we wrap this up, put them in the comments now so we can address those. But yeah. So what does the rest of the, let's say, the next 2 years, what do they look like for you ideally?
Yeah, I hope we continue to grow Nicole Graber's panel. Like I said, she just started this month actually, and so she is accepting new patients, and that's kind of our personal tailored MD goals. But I really hope to grow the direct primary care movement in San Antonio in terms of talking 2 years, grow SADPC, maybe get another clinic on board with SADPC. And get more employers. I'm finding that we can really bring a lot of value to employers. We're just kind of starting in that space. We can save employers tons of money on their insurance. Even if they want to keep insurance, there's ways to wrap in DPC and still save 20, 30, even 40% on premiums with insurance. It's just hard for them to make that step because it is so different. But that's a space we're hoping to get into, and just grow DPC, and for the sake of the patients, for the sake of, I mean, the larger kind of economic toll of healthcare, I just see it as something that needs saving, honestly.
Yeah, well, Dr. Clements, thank you so much for your time. My name is Shankar Poncelet, and if you have found this information very helpful, and if you thought, wow, this is really a refreshing type of way to approach healthcare, consider giving this video some likes and share it with someone. I will definitely Dr. Clements, I will definitely share it in the FMMA group as well, because there's very likely other physicians that want to join SA-DPC. Amazing initiative that you have there. And then I wish you continued success, and I know we'll meet very soon, probably in the realm of what we do in FMMA.
For sure, looking forward to it. Thank you, Shankar.
All right, everyone have a great rest of your day, and that's it for now. Bye-bye.